Seminal vesicles. Seminal
Yes.
vesicles.
Yeah. Okay. Thank you.
In ejaculatory duct obstruction would be commonly detected by an ultrasound scan, most commonly by transrectal ultrasound scan, where they will see a cystic lesion. And in that case, that is due to dilated seminal vesicles, and the patients would be coming with obstructive azoospermia. And in such cases, in those two cases, the patient would be referred to a urologist for further management and treatment. And this is just a diagrammatic representation. Yeah. Hello.
To travel
Yeah,
here. When would you consider imaging in a patient with, in a patient with infertility after doing semen analysis and the hormone, or at the first instance, you will start with imaging, any imaging?
Now the recommendation here is like you start with standard seminal fluid analysis, and if there's no abnormality, say you have azoospermia with normal the endocrine tests, then the chances of the patient would be having a obstructive azoospermia. In such cases, the ultrasound scan, transrectal ultrasound scan is requested. That is the normal pathway. So not in the initial parts, but in the midway of the evaluation, the transrectal ultrasound is requested.
Scrotal ultrasound scan.
Sorry.
What about the scrotal ultrasound scan?
Scrotal ultrasound scan is also that is depending on the clinical examination. Now, say what they recommend is if one of the most common causes of male factor subfertility, like for about 60%, correctable causes includes bilateral varicoceles. So in that case, if you're suspecting that the patient is having varicoceles, then a scrotal ultrasound scan is warranted. That is in the initial part of the examination. But transrectal ultrasound scan is based on the endocrine and seminal fluid analysis.
Nalin, Nishant here. What would you request if you ask for imaging for an obstructive azoospermia? What is the scan you request, and what findings would you like to see?
In obstructive azoospermia, I would request for a transrectal ultrasound scan to see whether there are any cystic lesions in the prostate. That is to detect if there are any obstructed seminal vesicles. And if the physical examination, you say you can't find that there is, you can't palpate the bilateral vas differences, then a scrotal ultrasound scan would be requested.
Yeah, I think in addition to that, there are some measurements to suggest whether there is a seminal vesicle level obstruction. So they usually ask for measurements of the seminal vesicles, which will indicate whether there's an obstruction. As the other thing is a cystic structure in the midline that you said. Yeah, go ahead. Thank you.
And once you've come to a diagnosis, the methods of therapy are limited. Actually, methods of treatment are very limited. And in certain limited occasions only, you can offer treatment for male factor subfertility. And now, most of the cases, like say, if there's a severe damage to seminiferous tubules, there's no therapy available at the moment, even in advanced technological countries. Now, say these certain etiologies, like say Klinefelter syndrome, bichromosome microdeletions, and Sertoli cell only syndrome, these type of diagnoses would not have generally an effective treatment in male factor subfertility treatment. But in those cases, what can be done as clinicians would be to generally support the patient. You can try testosterone replacement, but that will not restore the fertility. It will help to improve the patient's symptoms of hypogonadism. And in certain cases, retrieval of spermatozoa or spermatids from the testicular biopsy can also help in having for ICSI, but this technology is still not available in government sector in Sri Lanka. But the Castle Street Hospital for Women says is that they are going to start embryo lab in the near future, and that will be available at Castle Street Hospital in near future. And there's a growing evidence or the growing interest about germ cell transplantation, but that has many ethical issues at the moment to be discussed. And specific treatment for male factor subfertility is available only for hypogonadotrophic hypogonadism, where the medication, the treatment-wise, if the patient is having specific lactotroph adenoma, that can be treated with cabergoline or bromocriptine. And if the cause for hypogonadotrophic hypogonadism is due to drugs, like say the patient is on spironolactone or certain other thiazides, then the stoppage of medication would also help to treat the hypogonadotrophic hypogonadism.
Nalini, you have 5 more minutes only, please. Only 5 more minutes.
Now, these are certain treatment options, but which have an uncertain efficacy so far. So these do not have at the moment a very strong evidence to say that this will help to overcome male factor subfertility. And infections in the infections, like say if there are accessory glands or if there is testicular infections, that can be treated with antibiotics, and that will also be an empirical with an empirical treatment, and that will also help to slightly improve the fertility rates of a subfertile man. And varicocele, as I said, it's about 60% of the cases. Varicoceles will be present in male factor subfertile males, but as I said earlier, to characterize the varicocele, it's not indicated to do imaging. But when you are planning to treat this patient, imaging studies would be indicated. And the treatment of varicoceles are indicated only if the varicocele is palpable and in a patient with abnormal seminal fluid analysis with a documented history of infertility, and when the patient's the partner or the female partner do not have a non-curable fertility issue. So in those situations only, the treatment for varicocele is indicated. And in ejaculatory duct obstruction, this is one of the diagnoses where urologists come into play. Now, in those situations, we can offer transurethral resection of the ejaculatory ducts so that the patency of ejaculatory ducts are restored. Now, this is similar to as of a transurethral resection of the prostate, but the resection would be carefully done until there is an opening of the ejaculatory ducts are seen. And intracytoplasmic seminal spermatozoa infusion is also one of the treatment options in those cases where you cannot or where the patient does not in cases patients might come back after a vasectomy, but surgical reanastomosis have been shown to be having good outcomes, but preferably it should be done within 5 years of initial vasectomy. That is because after 5 years, most probably because of the disruption of the blood testis barrier, there will be anti-sperm antibodies being developed. So that within 5 years, they have shown that the results are better if you do a reanastomosis in a past vasectomy patient. And the empirical therapy for male factor subfertility do not have strong evidence to say that they will improve the chances of fertility, but these will be of supportive element or like a placebo effect in male factor subfertility. And assisted reproductive techniques are the only hope when there is inability of production of adequate amount of spermatozoa seminal fluid. That includes intrauterine insemination. And what they recommend is, now say the patient is having mild male factor infertility, say you have not azoospermia, oligospermia, then initially the couple should try at least 6 cycles of IUI. If fails, only then go for a ICSI. And these are the indications for ICSI: severe deficits in semen quality, obstructive azoospermia in certain cases where the facilities warrant, and non-obstructive azoospermia also there is a place for ICSI. And this is usually the pathway that they follow in developed countries when there's abnormal seminal fluid analysis results. They will be categorizing it into moderate to severe or mild disease, mild abnormality. So if it is moderate to severe abnormality or azoospermia, then the patients or the couples would be straight away directed to ICSI. And if it is mild, they will initially try with IUI, though it says 3 trials. Usually what they recommend is 6 trials of IUI. If failed, go for ICSI. So out of these, what we understand is now ICSI is having a greater chance of concealment. So failing IUI, anyways, the patient ultimately will have to go to ICSI, but I don't think it's available in Sri Lanka at the moment. Thank you.
When would you consider abdominal ultrasound scan in a patient with subfertility?
Sorry, I didn't get the question, sir.
When would you consider or do abdominal ultrasound scan in a patient with infertility? When would you, is there any suspicion?
That is, now if the patient is having bilateral absent testes, then if the patient is having undescended testes, the transabdominal scan would have a limited value, but apart from that, there is no place for transabdominal ultrasound scan in male factor subfertility, because what we are trying to see is whether there's a defect in the pathway of transition of spermatozoa from the testis into the external meatus. So from the abdominal ultrasound scan, what we can see is the prostate only, which will have a limited or inferior quality regarding the prostate assessment. So if at all, it would be a transrectal ultrasound scan.
If a patient comes with left side varicocele or bilateral vas difference obstruction?
Then there is a place, because varicoceles, we have to go for transabdominal ultrasound scan.
And even bilateral vas obstruction also, there's a chance of penile agenesis. Thank you, Nalin. Thank you very much. Any comments, questions from expert panels?
Nalin, Manoj here. Nalin,
Yes,
what else would you, on examination, if there is any obstruction at the ejaculatory duct level, what else would you be able to find during examination? Other than, for an example, congenital absence of vas difference or ejaculatory duct obstruction, what else would you be able to find? So usually what they say is you can feel tense epididymi, distended tense epididymi. Same thing you will see post vasectomy patients.
and in certain cases, if there is a beaded appearance in the vas when you palpate,
Yeah.
that also would suggest that there is a obstruction in the vas difference.
Okay.
Nalin, you heard of any syndrome with bilateral seminal vesicle obstruction? just to sort of add some knowledge to the discussion.
I can't remember, but there are, I can't remember the name exactly, but I think it's Cartgener syndrome.
It's actually the Sinner syndrome, right? So that is the it's a triad of Mullerian duct abnormalities and bilateral seminal vesicle obstruction with a cyst. So that can come time to time, you know, that might appear in the MCQs.
Neville sir, Ajit sir, any comments, sir?
So, I think is there any place for testicular biopsies during evaluation of the subfertility, sir? Neville sir. So, Ajit sir.
Yes, Suranga, that's a nice question, because now what they advocate is that rather than thinking of a testicular biopsy,
Yeah.
one must have all the information and straight away go with the intention of harvesting sperm. So it must be a combined thing where you actually go to do a testicular sperm extraction. And at the same time, if you're uncertain of whether it's obstructive or non-obstructive azoospermia, then you can, for documentation's sake, send a sample for histopathology as well. So in a setting where testicular harvesting and ICSI is available, in that kind of logistical scenario, then we must always go for a testicular sperm extraction along with a biopsy, but not think of a biopsy straight away. And also, I think Nalin mentioned that he wasn't sure that whether ICSI was available in Sri Lanka. It is definitely available in the private sector. And I think, as he correctly said, they are trying to set up a unit at Castle also. Thanks.
What is the place of vasogram in patients with subfertility, sir?
I think at the point of thinking of a reconstruction. So, for example, if you are having a patient who has azoospermia, and you are thinking of taking the patient to theaters where, you know, for example, let's say there are some features saying that it is possibly obstructive, then at that point when you open up, I mean, it is suggested that you anyway possibly do a testicular sperm extraction, because at least you will have some cryopreserved sperm firstly. Then at that point, doing a vasogram is beneficial, because you can actually see where is the obstruction and decide whether you are going to try and if the obstruction is more distal and more at the level of the ejaculatory ducts, then it's a completely different procedure, versus if there is no obstruction documented at that point, then you are thinking more of a vasoepididymectomy. So yes, in selected patients where there is a possibility of obstructive azoospermia, yes, vasogram is useful.
Yeah, Neville sir, if a patient comes and oligospermia, all the investigations are normal, including ultrasound scan and FSH, and everything is normal. How you manage, sir, to increase the sperm count? Sir, your mic is muted.
Can you hear me now? Yeah.
Yes, sir.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Yeah. Oligospermia, I think actually you start by doing IUIs and IVFs using the patient's own semen with the sperm concentration methods. So if there's nothing correctable, then other than using its own sperms after there are various swimming up techniques like that. Various techniques are there to concentrate the sperm concentration and then use it for IUI or IVF. So if there's nothing correctable, and if the first line fertility techniques don't work, then you have to actually go for more advanced techniques like ICSI. And so that's how I will manage. So because correctable, then there's nothing more to do. Like if I, on the same point, if I can make 2 comments, doing rectal ultrasound, transrectal ultrasound, I think I just, it's my practice, I just keep it for people with oligospermia. Oligospermia is not oligozoospermia, it's a low volume. Aspermia is low volume, so those are standard nomenclature. So if the volume is very low and the fructose levels are low, then of course there is an indication to look for seminal vesicle and ejaculatory duct obstructions. But routinely doing transrectal ultrasound might not be practical in all patients with fertility, especially if the semen volume, as you know, about 70% of semen volume comes from seminal vesicles. So I will confine myself to that. Another comment to make is that, as Manoj said, in the ultrasound, if there is very prominent epididymis, then that shows that there's a certain amount of obstructive azoospermia there. And the vasography, about vasography, to make a comment, we have done a trial long time ago, about 15 years back. I think we did vasography on everybody, and we found nothing actually, except people who have had childhood hernia repairs or some sort of even adolescent hernia repairs and various types of inguinal procedures. Only, I think those people only, very few showed any obstruction in vasography. So rather than, because the main problem in this obstructive azoospermia in the vas is that the cilia are not working. Not that there is a mechanical obstruction. There is a patency there. So there's nothing to correct when you do the vasogram, but the ciliary action has gone. The same is true for delayed trying to repair the vasectomized people. Earlier, the timeline was 8 years. If you try to repair them, their success rates are very low because vas has got atrophied and then vessel cilia are not working at all. So oligospermia, that is the thing. And then about the testicular biopsy, one thing, quick comment. I think though, when it comes to testicular biopsy, if the stimulatory hormones are very high and the testicular volume, which is very important to be measured in ultrasound, scrotal ultrasound is a must for all subfertile males. So I don't think I will be selective in that case, because you will detect varicoceles, sometimes even subclinical varicoceles, because varicocele grade and the final results not shown a very direct relationship. So even finding impalpable varicocele with the flow reversal, grade 2 varicoceles, especially bilateral, correcting them might be useful. So scrotal ultrasound will pick up that, plus the testicular size. Earlier we had this Prado occiometer, where there is a set of prosthesis-like things. You can measure the testicular size. Now, of course, we don't use it because ultrasound will give us the testicular volume. So if it is around 20, 25 is the usual volume. If it has gone down to say 10 or 15 or very small volume with high specific level, there's absolutely useless doing a testicular biopsy, because the report is going to be maturation arrest or some sort of a testicular failure. So I will avoid in those cases. But when it comes to normal size testes with the normal hormone levels, as Ajit said, rather than doing a pre-biopsy, previous biopsy before the fertility treatment, there is a slight theoretical disadvantage of breaking the blood testicular biopsy. It is a theoretical disadvantage. I think that the best thing is to combine both. But doing before that, I mean, in the practice, I think what we do is we still go ahead with biopsy before the fertility treatment, because advanced fertility treatment is accessible to only a limited number of people. So to come to a diagnosis, we generally go for a biopsy. And Professor Harsha Srinivaratna and myself, I think we conducted sometimes back a combined study to find out the outcome of these biopsy reports, the report what is reported in the biopsy with the final, when you are trying to do a ICSI or IVF, when you do the testicular sample for that, whether there is any relationship. But that study, the outcome has not, we have not published the final outcome yet. So these are few comments I would like to make. So,
Navil sir, have you any encountered people who have bodybuilders who are coming with the subword?
Bodybuilders?
Oh, yes, bodybuilding. Who are doing the bodybuilding?
Bodybuilding and the subfertility, the only connection I can think of is anabolic steroids and various types of steroids which can affect the pituitary hypogonadal and pituitary gonadal. But other than that, do you have an experience in having a special connection between bodybuilding and subfertility? Because I can't think of a theoretical.
Yeah, yes, I also think it's hormonal.
Yeah, it is basically what they take sometimes. You know, they take various whey proteins and various unidentified things plus steroids, anabolic steroids. So those might be having
androgen.
Yeah.
They have get androgen for the increase of muscle bulk, sir. So androgen, exogenous androgen cause kind of testicular atrophy.
Exactly, because earlier everybody with subfertility was given testosterone, proviron or injectable testosterone, which was a very bad practice. And nowadays, unless you have hypogonadism, proven hypogonadism, testosterone treatment is not going to help at all.
And Ajit sir.
Yes, Dr. Bali. Yes, Dr. Bali.
If you are going for a ICSI for a severe oligospermia, will you do a Y chromosome microdeletion before the ICSI?
Yes, I would do a karyotype and the Y microdeletions, because if the microdeletions A plus B combined are present, then there is zero chance of getting any sperm, and therefore there is no point in doing that. While on the other hand, the other combinations, and for example, if it is a C microdeletion, we have quite a very good chance of getting sperm. So yes, I would do a karyotype as well as microdeletions and avoid doing a testicular sperm extraction if the Azoospermia factor A and B are both deleted.
Thank you, sir. So trainees have to know about the azoospermic factor A, B, C, and what are the difference. Right. One more question, sir. In your practice, what kind of sperm retrieval method you usually do? Is it PISA or MISA or TISA or TESI? What?
I do a microdissection TC. Unfortunately, I have not been able to get the paraphernalia for a micropipette extraction from the epididymis, but I think that, of course, would be a useful thing to do. I know I don't know whether any of you all were listening to that. There was a lovely webinar from Rupin Shah and others last year on fertility, male subfertility webinar. They, of course, routinely do percutaneous aspirations in the office, and if that fails, only they go for the microsurgical aspiration of the epididymis, and if that fails, then they will bivalve the testes and go for a standard microdissection testicular sperm extraction.
So you have the microscope, sir?
Yeah, I mean, fortunately, I work in the private sector, so a microscope that the neurosurgeons use or the ENT specialists use, so a minimum of maybe 10 factor microscope would be more than enough to do a microdissection TC.
Okay, sir. If you get a grade 1 varicocele with oligospermia, will you go for a varicocelectomy?
No, as Professor Neville Perra mentioned, it's a very subjective area, and in my practice, I would say at least a minimum of grade 2 with a soft testes and the impaired sperm factor numbers, and definitely a grade 3. Those are the ones that I would select out.
Okay, sir. Do you use clomiphene citrate to increase the sperm number in males?
Very sparingly. For example, if there is sperm factor abnormalities and the FSH is either normal, and especially if the LH is either normal or low, and the testosterone is also at a low normal or maybe even hypogonadic. So if the FSH is high, I would not use it because there is no use for it at all. But yes, if the FSH is normal low, LH normal low, and also testosterone normal low, then yes, I would try a course out of 3 months, 25 milligrams once daily.
Okay, sir. If everything failed, what is the reception about our population regarding donor sperm?
To be honest, I think Prof. Neville Perra would be having much more expertise on that rather than me. But in the private sector, I mean, it all depends on how we also communicate it to them, and the fact that we get the couple to discuss that. But I have found that maybe 10%, 20% of people who fail with testicular sperm extraction techniques or even are following ICSI, IVF, sometimes they do consider that. So it is a little on the lower side, but if we discuss with them, I think they do accept it. Prof. Neville Perra would probably have more experience on this than me, I think.
Yeah, it's true. I think I agree with. Hello, can you hear me?
Yeah, we can hear you.
I agree with Ajit. Yes, because they are due to socio-cultural acceptance. Poor acceptance. I think a lot of people for donor sperms, and also the expenditure is sometimes inhibitory when it comes to when it comes to assisted fertilization. We always suggest that this is a cheaper way of doing it, either donor sperms, or it may be AID, that is artificial insemination by donor. But people generally leave us saying that they will consider that and come back. But I think even less than 10%, so far I have not come across that even less than 10% people ultimately go for that. But I'm not quite sure about the other end at the fertility centers. There are several fertility centers in Colombo itself. So what their experience is, I'm not quite sure. But I think if they are going for the donor sperms, I think the AID is the cheapest artificial insemination by donor if there is no female subfertility factor. So they sometimes, they just go on like that, and sometimes adoption will be taken as an alternative.
Thank you, sir. The last question before move, Ajit sir, in the private sector for a sperm banking, how is the cost? First question. Second question is, how long they will keep the sperm? Is it 10 years or 5 years? Third question, do they do HIV and hepatitis B before doing the sperm banking?
When you say sperm banking, is it the cryopreservation from a
yes, sir.
TC?
Yeah.
Yes.
Cryo.
Yeah. Yeah, so that's not a huge cost. I think it's about 3,000 to 5,000, and if I remember right, it's for 3 years. After that, one will need to sort of pay beyond that. So even some of the patients who come in for orchidectomy, the testicular tumors, I get them to donate and cryopreserve. So it's not that exorbitantly costly. So yes.
I think time is up. You can move to the next topic. Taha and Dr. Solanga.
Yeah, we'll move to second topic, that is Peyronie's disease and the penile curvature, will be done by Dr. Sanjay Marasinghe. Dr. Sanjay, are you there?
Yes, sir. Can you all see my slides?
Yes, yes.
Hello.
Sanjay, you have 10 minutes, please.
Okay. Can you all see my slides?
Yes, sir.
Okay. I am Dr. Sanjay Marasinghe, Senior Registrar, Genital Surgery, currently working in the National Hospital, Kandy. So my topic is to discuss regarding Peyronie's disease and the penile curvature. So when you're considering penile curvature disease, there are mainly two types. One is a congenital, other one is a acquired. Acquired one is called Peyronie's disease. Today I'm going to talk in more in Peyronie's disease. So what is Peyronie's disease? It is actually a type of a wound healing disorder. So which in the abdominal scarring in the tunica albuginea of the penis, which cause exuberant scar probably following the etiology of trauma. So what happens there's an abdominal remodeling of the scar tissue, which cause changing the penile shaft, which cause indentation and curving of the penis, and which leads to shortening of the penis, and it can associate the pain and the also erectile dysfunction. Prevalence is around 3 to 20%, but the patients with the erectile dysfunctions and the patients with the diabetes have more prevalence of Peyronie's disease. This disease is mainly present in the 5th decades of life, but it can present in patients in the teenage age group or even late 70s also. And this Peyronie's disease is associated with several conditions. Mainly, one thing is aging. Aging means after 30 years, there is a gradual increment of Peyronie's disease prevalence, but when you come to the 5th decade, there's a drastic increase in the prevalence. In the patients with diabetes, mainly the patients with poor control and long-standing diabetes patients, there are high chance of prevalence. And that is due to the long-standing diabetes can cause abdominal wound healing with the abdominal collagen formation. Those are the hypotheses they are described. And also, patient with erectile dysfunction, chance of they have Peyronie's disease, around 50%. Patients with erectile dysfunction can have 50% of Peyronie's disease patient can have erectile dysfunctions. So that is, they are describing the erectile dysfunction can cause less strength of penis during sexual activities. It can bend and cause microtrauma of the penis can lead to this condition. And other association is the patients who undergone radical prostatectomy have detected high peroneus disease, mainly if the patient, they are undergoing radical prostatectomy in the more young age. And the other thing is the hypogonadism. Patients with the peroneus disease, they have hypogonadism, they can have worse symptoms. Other thing is the patients with the collagen disorders, like patients with the debutant contractures and Ledderhose disease, that is the fibrosis of the plantar fascia. They are associated with this condition. The peroneus disease, considering the natural history, they have mainly two phases. One thing is the active phase, and other one is the chronic phase. Active phase, these patients have mainly a painful erection and the gradual change in the penile deformity, curvature. And even they can have pain in the flaccid state of the penis also. But in the chronic phase, deformity is stabilized and patient will, pain will disappear. And this peroneus disease, there is less chance of spontaneous resolution of this disease. It's about 13% of patients can have improvement in their deformity, but the majority have persistent their deformity. So when you consider in the penile shaft, the tunica albuginea of the penis, they have mainly two layers. One thing is the inner circular and the outer longitudinal layer. So this outer longitudinal layer is less in the 3 and 9 o'clock area, and it is absent in the 5 to 7 o'clock areas. Mainly the outer longitudinal area is more in the dorsal aspect of the penis. So what happens in the etiology, probable etiology of the peroneus disease, they describe the trauma is the cause for peroneus disease. So what happens in the erect penis, when it bends, so mainly because of this outer longitudinal area is the dorsal side, so it bends upwards, so that causes the delamination of this inner circular and the outer longitudinal area, causing bleeding into that area, and which cause inflammation and the fibrosis. So that's why the people with peroneus disease, it is more commonly about 70% of patients have dorsal curvature because of they have a more longitudinal area that area. So this is the histological appearance of patients with the peroneal disease plaque. So upper one is they have normal collagen polarized arrangement, but in the second one there are non-polarized arrangement in the collagen tissue. Etiological wise, they describe the penile trauma is the cause for peroneal disease. So it causes people who susceptible to the peroneus disease. What happens in the normal trauma, normal healing mechanism, there's inflammation, proliferation, and remodeling. But these patients have abdominal remodeling process. So it causes excessive production of collagen, and which leads to penile plaque. So in these patients, for presentation, so we have to evaluate the patient. Initially, what's the complaint of the patient? Whether the patient is having pain, or whether the patient is having any deformity, and also the associated erectile dysfunction, which is important in the management, whether the patient is having erectile dysfunction is there or not. And
you have 4 more minutes, please.
Sorry?
4 minutes, please.
Okay. And also other thing is we have to question about the patient sexual function, whether this penile curvature is affecting their sexual function, and also we have to examine the patient in the penis. We have to examine the penis in stretch, and we have to check the stretch penile length, which is important to decide the management option. And and other thing is sometimes we can use the photography of the penis as ask the patient to take the photography and to assess the how the degree of bend. Because sometimes some people they overestimate the curvature. So penile deformity can be assessed in mainly 3 ways. One thing is home photography. Other thing you have to inject vasoactive injection into the corporal body and assess the penile deformity, and other things using a vacuum-induced device. AUA recommendation, if you are going for the surgical management of Varicocele disease, they are recommended to do the intercorporeal injection prior to the surgery. This is the initial assessment of the penis. We can assess with the ultrasound scan. We can detect the plaque in the tunica, and also there it shows posterior acoustic shadowing with the plaque. And also duplex ultrasonography is important in the Varicocele disease because these people have erectile dysfunction. So assessment of penile vascular parameters important to detect whether the patient have erectile dysfunction also. Management of Varicocele disease it depends on whether the patient have active disease or stable disease, and we have to discuss with the patient regarding the sexual disability. And in the active phase, mainly patients have pain, and that is patient is in mainly active phase. And initially we have planned for the conservative management, but stable phase, stable disease, there's no pain, and we have assessed the penile length and what is the curvature, degree of curvature, and whether the patient is having any hourglass deformity and erectile dysfunction is there or not. Depending on that, we have planned for the management. There are several non-operative treatment options, and there are oral treatment, intralesional treatment, and the topical treatment. So most of these oral treatment have study shows none of them have good in reducing the penile curvature and the length. So only the pentoxabalin has some effect, but most of the AUA recommendation or EU recommendation, they have not suggest to start this oral treatment. But intralesional treatment, mainly verapamil and the Clostridium collagenase injection into the lesion can have benefit to reduce the penile curvature and the improve the penile length. And topical treatment mainly is traction device and the vacuum device have benefit in improving the penile curvature, and extracorporeal shock wave treatment we can give only to manage the pain, but it not improve the penile curvature or shortening. These are the AUA guidelines. So they are recommended NSAIDs if patients have pain, and oral treatment, most of them they are not recommended. And intralesional verapamil and extracorporeal shock wave therapy and the Clostridium collagenase they are recommending in the initial conservative management of Varicocele disease. Indication for surgery, patient should have stable disease. So we have to wait until at least 6 months, and we have to ensure that patient doesn't have any pain, and curvature should be stable, and also it should be affect patient sexual intercourse, and this indication is there. We can go for surgery. So surgically, there are several methods. Prior to surgery, we have to assess the penile length, curvature, and whether the patient has erectile dysfunction. Whether it's erectile dysfunction means respond to pharmacotherapy like phosphodiesterase inhibitors or not, and the patient expectation. So if patients having, there are 3 main types of surgery. One thing is that penile shortening method, other thing is lengthening method, and the other one is the penile prosthetic implant. So patients shortening procedures can be used if patients having good penile length and without any erectile dysfunction. There are this is called the Nesbet procedure. We do the elliptical incision and suture transfers. And this is another technique. It's called Yachia procedure. We full thickness vertical incision and suture in the transverse manner, like in the Henn-Mikulek's procedure. This is there's no incisions. This is called dot procedure. We have use plication of the penis with the Lambert type of sutures, with permanent sutures, Lambert type of sutures. These all methods need penile declaving, and this is also another method which is called tap procedure. There's a type of tunica albuginea plication. These shortening procedures, what the problem is that it reduces the penile length of patients with the short penile length. This procedure is not recommended because it can cause further reducing the penile length. And they have good cosmetic outcome and good results, more than 80% of penile curvature correction with these methods. And if the patient is having a problem with the shortening of the penis, and if patients having good erectile there's no erectile dysfunction, then they can use the lengthening procedures, which is called excision of the scar tissue and grafting. So there are several grafts used for this lengthening procedure. There are autograft, allograft, xenograft, and synthetic grafts. And most of these grafts have same outcome, and there's no different outcome. And problem is this lengthening procedure is while we are removing this tissue, this scar, there's chance of erectile dysfunction with the venous leakage. So, so people with erectile dysfunctions, so it can further reduce their erectile function with this lengthening procedure. So, those patients who have erectile dysfunction, the main treatment modality is penile prosthesis. So, so it improves the patient's both Peyronie's disease and the erectile dysfunction both. So some people, they need intraoperative modeling of the penis while they are doing the penile prosthesis. And so sometimes it can become, it should be combined with the other shortening procedure like plication procedure with the penile prosthesis. So the main complication, one of the complications that happens during this penile modeling with the prosthesis is there are chance of risk of urethral perforation. And those are mainly, I'm talking about this Peyronie's disease, and congenital penile curvature is it's a rare condition, and it's actually...
Can you quickly finish?
Yes, yes, sir.
Okay, you quickly finish the...
Hello?
You can quickly finish your rest of the presentation.
This is actually disproportionate development of the tunica albuginea, which can actually present during the puberty with the erection. So management is same like Peyronie's disease, but we have to defer the treatment until patient is attain the puberty. Thank you, sir.
Thank you, sir.
I think Manjula Vijayavardhan sir is here. We can ask his experience about the management about the Peyronie's disease. Manjula sir, what kind of non-operative management you use to manage Peyronie's? Okay. Neville, sir?
Yes. Basically, so what is important is that you must assess the patient properly so that you have to make sure that how sexually active he is. Because some people, for the sake of straightening it up, they come and complain that there is a lump which is felt there, and they are actually Peyronie's plaque makes more anxiety, but rather than the bend. And very sort of extreme penile curvatures are seen in the minority. So you can assure the patient, because his main worry is that whether he's a cancer or not. So reassurance of the patient, and then very clearly ask about his sexual activities, the frequency of sexual activities, how far it is affecting the partner. These things are sometimes overlooked and people don't ask. It's very important because some people are not sexually active at all. So they are just worried about that this is a slight bend there, about 10-15 degrees, and the lump. So if you can reassure them that this is not going to affect their sexual life, then I think you can save them from undergoing any kind of surgery or any kind of treatment. Because there's no, drugs like vitamin E, Portaba, and all vitamin A, everything has been given and everything has been injected, including hyaluronidase and various types of enzymes have been injected to the plaque without much results. So because of that, I think reassurance is important, and identify the minority of people who really needs this curvature to be corrected. So that is one thing. And then you have to very clearly tell them about the problem of post-surgical erectile dysfunction. So because especially if you are doing surgeries like Nesbit, even Nesbit is rather safe, but Yashia, where you cut the tunica albuginea, there's a slight chance of venous leak, and the erections might get weakened. So that has to be told to the patients very clearly. When you tell that, if he is already having a good sexual function, they say there's a chance that it might go, but the penis will be straight, but your sexual function might get affected, then I think they think twice before they come for surgical treatment. So I think, in my experience, I think of these people, people who have difficulty in penetrative sex, and people who really need it are the people whom we should consider for either Nesbit or any other surgical procedure. I think we must ask the others as well their experience. Manoj and I'm sure Ajit has.
Sanjay, this is Dr. Sohan here.
Yeah, Sohan is out there.
Yeah, sir, I just want to discuss about the shortening thing. Now, how do you advise patients about the angulation and how much you are going to shorten your penis? Like rough guide. Now, when we are telling about shortening, we have to tell them like you will be having this much of shortening.
Yes, 1 centimeter is the usual shortening you get with a Nesbit, roughly about 1 centimeter. So you have to clearly see a photograph. Nowadays it's easy because of the camera phones, but earlier, my early days, it was extremely difficult, and we tend to do these saline erections, on-table saline erections, sometimes under anesthesia, to get an idea about the angulation and the bend. But nowadays, of course, with natural erection, if it is there, they generally bring the photographs. So once you study the photographs from side and the top, you will know which way it is bending, and then you might be able to explain the patient, if you do a contralateral Nesbit plication, contralateral side, it might get straightened up. Sometimes we have to cut in several places. So, but shortening wise, I would say, I would show them my digit here and say that this is 1 inch, and shortening will be 1 to 2 centimeters. That is about this much, say about 1 to 2 centimeters.
So there was a workshop with Mr. Minhans, Saks Minhans.
Yeah.
What they were telling was every 30 degrees you will lose 1 centimeter.
Right.
Like to be precise. So if it is 60, it's 2 centimeters.
Yeah, that's probably true. I think more the bend is that more you have to reverse the bend and plicate it so that the length will be short. So that's a good guideline.
So the expert you have
So one
experience with-
comment. Yeah, one comment, Sanjay. You said penile lengthening procedure, excision and grafting. You should not excise the plaque. What they do is you have to incise the plaque. Incise just up to the erectile tissue. Sometimes you might have to incise over the calcium deposited plaque. Sometimes it may be very, very difficult, but still you are not going to excise. If you excise, that is it. You definitely will be ended up with erectile dysfunction. I worked in andrology what do you call center. Their guidance is less than 60 degree nest beats. And if the patient has adequate penile length, if the patient is happy to have 2 centimeters shortening of the penis. Otherwise, more than 60 degree hinge deformity or hourglass deformity, all patients were counseled for loop procedure or incision and grafting.
So when you do an S-pin plication, so how do you know whether it is corrected or not? So how much millimeters you have cut, like elliptical and or when you are doing the plication? Is there any relationship between the angle and the width of the elliptical incision?
Yeah, Suranga, once the surgery is done, you can always do saline erection and reassess.
And 1 millimeter, if you excise a 1 millimeter.
1 millimeter, yes. 1 millimeter or 10 degree.
10 degree, that is what they say. But 30 degree, rough guidance is 30 degree, you have to remove 1 centimeter. That is what they say. Maybe practical experience, but all books and papers says 1 millimeter, 10 centimeters.
Yeah,
10 degree.
Could I just add a little bit, Suranga? One practical tip is when we do that, we just put a butterfly cannula and do the saline erections. You can see the on-table correction with the sort of fine Alice clamp. So if you can just dissect the erectile nerves and then sort of reflect the nerve bundle, and then
Nishanda must be having some connection problem. So experts, what is the suture material you use? You use PDS or you use proline or you use Vicryl? What is the suture material for the plication or nest bit or for the grafting?
Grafting, Balagobi, if we have to unite 2 veins to get a good breath, middle part will be proline. Vein to vein, proline. Vein to Vicryl. Hello.
In a plication or nest bit, you use non-absorbable or absorbable?
They used. I don't know. In my center, we used to use Ehibond, non-absorbable.
Yeah. Then we had to bury the knots, isn't it? Otherwise, patient will feel the.
Yes, that's true.
Some people say PDS also good because it lasts for about 120 days without, and knots is a problem, isn't it? If they feel the knots is
should we avoid spontaneous erection? And if it is so, how long and what will you use?
Yeah, Taha, what they say, practice should be for incision and grafting, you should give maximum PDE5 dose to promote erection from the post of day 1. Otherwise, venous graft will shrink and the curvature will be persistent. So you have to promote erection, adequate painkillers and adequate PDE5 inhibitors. That was the practice.
Thank you.
Thank you.
So we move to the third topic. It's a varicocele done by Dr. Niroshan Kodikara. He has 10 minutes and I hope he finish in the time. Over to you, Niroshan.
Good evening to all of you. I'm Dr. Niroshan Kodikara. I am currently working as a senior registrar in Colombo North Teaching Hospital. And today I'm going to present regarding varicocele and its management. Varicocele is actually an abnormal dilatation of the pampiniform plexus in spermatic cord and the testis, and ultrasonically the diameter of this dilated veins in pampiniform plexus has to be more than 3 millimeters to call it as a varicocele. And varicocele is having a relatively high prevalence because it's prevalent in about 15% in general male population, and the prevalence has increased up to 35 to 40% in men who's undergoing evaluation for infertility. And there are 4 categories according to the WHO classification. Basically, there are subclinical varicoceles and clinically apparent varicoceles. Subclinical varicoceles are basically diagnosed only on ultrasound examination or color Doppler examination, whereas clinically apparent varicocele again divided into 3 grades, grade 1, 2, and 3. And grade 1 varicocele is actually a varicocele which is palpable only on Valsalva maneuver, and grade 2 varicoceles are palpable and even at rest without without demonstrating the Valsalva maneuver. And grade 3 varicocele is not only palpable and it can be easily visualized on examination. Then when it comes to the pathogenesis of varicocele, the most when you consider the prevalence of the varicocele, the 75 to 90% of palpable varicoceles are found on left side. So the most popular theory is the left gonadal vein has a right angle drainage into the left testicular vein. Because of this right angular drainage, the prevalence of the varicocele is more on left side in contrast to the right side, because the right gonadal vein is tend to drain into the IVZ in an acute angle. And also the other explanation is when there's a varicocele occurrence, there will be venous insufficiency causing retrograde flow and pooling of the blood in the pampiniform plexus. So these two pathogenesis leads to primary varicoceles, and there's another entity called secondary varicoceles which occur due to a secondary cause like external compression of the gonadal veins due to mass in the retroperitoneum leading to somewhat called non-reducible varicocele. So when there's a right-sided varicocele as well as when there's a large varicocele on right side, on left side, which does not collapse when the patient is supine, we have to consider about this secondary varicocele and a pathology which leads to retroperitoneal obstruction of the gonadal veins. And varicoceles are commonly associated with male subfertility. There are several theories and hypotheses to explain how a varicocele causes male subfertility. The most popular theory is that the presence of varicocele leads to disruption of the countercurrent mechanism, leading to raised intertesticular temperature, leading to reduced spermatogenesis. And there are three other theories. One is there are certain heat shock proteins such as HSPA2 protein, which actually reduces the thermal injury to the spermatogenesis, and they have found there's a lower expression of this HSPA2 proteins in patients having varicoceles. And the other explanations are there will be oxidative stress and development of reactive oxygen species in men with varicoceles. And when it comes to the left-sided varicocele, another popular theory is there can be free reflux of gonadotoxic renal and adrenal metabolites through the left renal vein into the left gonadal vein. In turn, it will cause reduced spermatogenesis on the left side, and also leading to subfertility in the patients with varicocele. And the diagnosis is varicocele can be made clinically. We do not need ultrasonic confirmation or the ultrasound scan to diagnose varicocele. So pathological varicoceles are defined as those that are palpable on physical examination. That is why we are not much worried about the subclinical varicocele, because there are studies which has proven the treatment of subclinical varicoceles does not improve the semen parameters and the fertility rates. So basically, if the varicocele is clinically palpable only, they are considered as candidate for the further management of the subfertility. And what are the indications for the varicocelectomy? So all the symptomatic varicoceles which are not responding to simple analgesics, those are painful varicoceles which leads to dull aching pain, are considered as a indication for varicocelectomy. Then the other indication is the infertility, but there are certain criteria to be fulfilled before we proceed with the varicocelectomy in a patient or a couple having subfertility. First of all, the female partner has to be evaluated completely, and she has either have a normal fertility according to these investigations, or she should have a potentially treatable cause of infertility, and the male partner should have an abnormal seminal fluid results that can be actually corrected after varicocelectomy. And the other requirement is, as I described earlier, the varicocele has to be clinically palpable in this male partner. So if these criteria are fulfilled, infertility or subfertility is considered as an indication for the varicocelectomy. And the other two indications are hypogonadism and the decreased testicular size. So this decreased testicular size again is considered as a criteria when we are considering a varicocelectomy, especially in adolescents who are not sexually active, because the studies have shown if there's a size discrepancy of more than 20%, those varicoceles are relatively indicated to undergo varicocelectomy, even though the patient might be an adolescent who is not sexually active. Then about the techniques of varicocelectomy. The varicocelectomy can prevent further testicular damage, and also it can potentially improve spermatogenesis and Leydig cell functions. So there are several options and approaches that we can follow when doing a varicocelectomy. Starting from the proximal side, so retroperitoneal approach, which is more commonly employed in children in Western countries, because in this retroperitoneal approach, an incision is made just proximal to the internal ring, and then internal spermatic vein, the testicular vein, is identified at the retroperitoneal space, and it is ligated while preserving the testicular artery. But in this approach, though we ligate this testicular vein at relatively higher level, there can be still veins communicating with the external spermatic veins and the cremasteric vein, and also the vena commitments following the testicular artery are still preserved. Because of this residual venous communications, the retroperitoneal approach is found to have a relatively high recurrence rate, but it is more commonly employed in children because sometimes if we proceed with other approaches, it might be difficult to identify smaller vessels in children. Then laparoscopic varicocelectomy can be considered as a kind of a evolution of this retroperitoneal approach. Here we use laparoscope and transperitoneal approach, and we identify the testicular vein when it exits into the peritoneum through the internal inguinal ring, and then ligate it there. The advantage of this laparoscopic approach compared to the retroperitoneal approach is because of the presence of laparoscope. With the help of the laparoscope, the surgeon is able to magnify and identify the this testicular vein more precisely, and it helps to preserve the artery and lymphatics without damaging them. So that is the advantage of laparoscopic varicocelectomy. Again, this laparoscopic varicocelectomy is also having a relative recurrence rate close to 12 to 13%. And
Diroshan, sorry to interrupt.
Yes, sir.
Do we have to preserve the testicular artery always in laparoscopic varicocelectomy, or we can?
No, sir. We can actually, the testicular artery can be ligated at laparoscopic varicocelectomy,
Right.
but it can lead to testicular atrophy sometimes, or reduced testicular growth. In turn, will lead to poor quality seminal fluid and the spermatogenesis. Again,
Okay.
then if it is done for the subfertility, the aim is not fulfilled if we go ahead
Right.
with this ligation of the testicular artery.
Thank you.
Then,
what is the nerve that can
yes, sir?
get damaged? What is the nerve that can get damaged when you are doing a laparoscopic varicocelectomy?
Ilioinguinal nerve and the
nerve that is
Gentofemoral-
similar location just front of the Schweiss muscle.
Gentofemoral nerve.
Very good, thank you. Yeah, you can proceed.
Then about the gold standard approach for the varicocelectomy is considered as a microscopic inguinal or subinguinal varicocelectomy. Here the advantage is because of the usage of microscope, we are able to precisely identify the these dilated veins in the pampiniform plexus, preserving the artery, testicular artery, as well as preserving the lymphatics. And one other advantage is in this microsurgical inguinal and subinguinal varicocelectomy, we are able to deliver the cord into the wound, and it is convenient to identify all the draining veins from the testis, including external spermatic veins and the gubernacular veins that can be potential sources of recurrence. So because of this microscopic, the subinguinal varicocelectomy has the least recurrence rate, which is about less than 1% or around 1%. And then about the conventional inguinal and subinguinal access, the difference between this inguinal and subinguinal access is we are not using a microscope, but still we can deliver the cord into the wound, and we can try to identify all the draining veins and proceed with the ligation of those veins, preserving the artery. But when to go for inguinal access rather than subinguinal access is when if you consider the varicocelectomy done in children, again inguinal access might be useful, because at that level the artery might not be branched much. So then again, we will be able to preserve the testicular artery compared to the subinguinal axis, where the testicular artery might be again branched into several small branches where it's difficult to identify. But the other thing is, if we are going for a subinguinal access, it is advisable if the patient has already undergone hernia repair, where the inguinal anatomy must have been altered, then subinguinal access is anyway preferable. And in some obese patients, and also the patients who are having these low-lying testes with a lengthy cord, then those are the candidates preferable for the subinguinal access for the varicocelectomy. And then the next approach. Sorry, sir. The next okay, sir. The next option is radiographic occlusion technique. So basically, we can do the percutaneous occlusion of the internal spermatic vein using coil embolization or sclerotherapy. This has actually found to have successful occlusion rates up to 75 to 90%. But the problem is, in the long run, these thrombosed or these obstructed veins recanalize, and the recurrences are common. So those are the options for the varicocelectomy and the pathogenesis of varicocele. Thank you.
Thank you, Manoj.
So Niroshan, what kind of varicocelectomy you will offer to your patients?
So if I have a microscope available, that again depend on the age of the patient and the patient's history and previous surgeries and everything. But still, in a normal day-to-day patient, adult patient, I would offer a microscopic subinguinal approach as the preferable method.
If you don't have microscope,
then I will go for the subinguinal conventional varicocelectomy.
What about getting a loops that is about 10,000, 20,000 and with the 5 times magnification, and you can do it, isn't it?
Yes, sir.
Right. Experts, in the era of microsurgical varicocelectomy, will you recommend laparoscopic varicocelectomy? Maybe sir, Ajit sir, Dr. Sohan, Dr. Manoj.
Laparoscopy has, can you hear me?
Yes, sir.
Laparoscopy has come, I think, as a sort of good training surgery for laparoscopy, to how to make ports and go into the abdomen and then identify the venal ligate. But when you analyze the long-term results, laparoscopic varicocelectomy results are inferior. So recurrence rates are high, about say 3 to 4 times more than standard open technique. And also you are converting a simple procedure which can be done in 15 to 20 minutes or maybe a little longer with the loops and dissecting the lymphatics and artery. A superficial incision, rather superficial incision into a laparoscopic procedure, which is associated with all the problems of laparoscopy. As you know, there's a long list of laparoscopic complications, and except for say bilateral inguinal violation has been done, and then in the childhood maybe, and the inguinal regions are all fibrous, and you are not happy to go through inguinal region and you have to do bilateral. But then of course laparoscopy has a place, because there is you are entering into a virgin area there. I don't like this Palomo, where you dissect the peritoneum just lateral to the deep ring, the Palomo procedure. So so laparoscopy will be a adjunct to if there's the inguinal regions are all fibrous and as previous surgery. But other than that, laparoscopy is just a good training tool than to be used as a standard procedure, because of its added complications. I use Ivanisevich, that is subinguinal approach, traditional approach, and then our success rates are keeping up with international figures of 32 to 36% of fertility rate. In Goldstein, where this microscope is used, it's generally about 40% or a little more. So one fine day when we have the microscope and the facility of having specialized andrology centers, we will go for that. But for the time being, I think it will be the Avinesevich for me.
Thank you, sir. Ajit, sir.
Another question for
Yes,
experts. What sort of techniques do you use for identification of the testicular artery during the dissections?
Nishanta, it's Ajit here. I have the luxury of having a microscope in theater, so that makes it a little easier. And sometimes I do instill papaverine as well onto the blood vessels to if the pulsations are not seen. But even despite that, sometimes the due to maybe manipulation, the pulsations cannot be seen. Then I would always go and ligate both ends to see, or at least ligate one end and see whether there is a pulsation that can be seen before I go to divide vein. So the ultimate would be to have a particular Doppler scanner that could really identify the vessel, and that has been shown in certain even randomized trials that one would identify even the small branched vessels when doing a subinguinal varicocelectomy. Thanks.
Thank you.
Married, coming with the palpable varicocele, which is asymptomatic, and the sperm counts are normal, how will you manage that? Will you do a surgery? A doctor, grade 3 varicocele, asymptomatic, testicular sizes are normal, and sperm count is normal.
Yeah, I think I would speak to him and tell him that, yes, a grade 3 varicocele, there is a potential for sperm count abnormalities at any point. However, from the evidence that the testicular size is normal, and also if I on examination, if it seems as firm as the other side, I would reassure him and tell him that, go ahead, wait until you try to have a kid, and if there is a problem, and if the sperm counts vary and go down, or there is any abnormality, yes, let's consider this. But otherwise, I would in no way do surgery on this person.
Suppose oligospermia and primary subfertility is referred by a gynecologist, a grade 1 varicocele, then how will you manage?
Again, I'm a little reluctant with grade 1 varicoceles because, as Professor Neville Pereira pointed out, the Cochrane analysis, systematic reviews, etc. Also, they do say that yes, the sperm counts do improve, but there is sometimes a sort of pros and cons of doing varicocelectomies. So grade 1, I would be very reluctant to operate on. Grade 2s, 3s, I would go ahead and do that. So again, grade 1, I would be very reluctant to offer varicocelectomy.
Thank you, expert. Any other opinion?
Well, in the absence of, I think evidence is there, as Ajit said, but in the absence of any other treatment, I think grade 1 with flow reversal, color Doppler flow reversal, grade 1 is kind of Valsalva positive varicocele. Because of the time scale, we don't know when he's going to get married and when is he going to be sort of trying to become a father is uncertain. maybe another 5 years or 10 years. We don't know about that period. So by that time, if there is any chance that he can become subfertile, then of course we might have missed the opportunity to cure him. So if there's no other reason, he's having grade 1 varicocele and is subfertile, that is sperm counts are low, I would rather offer varicocelectomy. I think evidence is divided. I think the opinion is divided here, but that is my practice.
So if a sperm count's going down after varicocele, what percentage of the people, sir, the sperm counts reduce after the varicocelectomy?
The problem is there is a natural variation, fluctuation of sperm counts in anybody. So you have to be extremely careful when you are when to repeat the next sperm count. If you do it too early, you might catch him up at a low sperm producing time. So then you will be blamed that you have done something to reduce his sperm count. So give it about at least 2 to 3 months, or 3 months or more before you repeat it. And only in very rare occasions we see sperm counts going down, because in unilateral varicocelectomy especially, so you have to probably think of some other reason. But if this testicular atrophy is a problem, I think in a small percentage of people, that also may be compensated by the other testes. So I'm not sort of practically, I have not come across any sperm reduction which can be related to the surgery. Do you have any idea in your mind?
There's a figure, they say that in 2/3 the sperm count increase, and in 1/3 there's an increased pregnancy rate. So in 1/3 there may be reduction in the sperm count. I don't know whether it's it's just a figure.
Right. No, I don't think I find it difficult to explain the pathophysiological basis, pathological basis of it. Maybe don't know whether the others have any idea.
Right. I think that, yeah, Taha, then we can move to the next.
Yeah, I see that Dr. Nishantan is ready with his slides. We'll move on to the next topic, that is vasectomy. It's going to be done by Dr. Nishantan. You have 10 minutes, doctor. Over to you.
I'm Dr. Nishantan. Yeah, I'm Dr. Nishantan from Colombo North Teaching Hospital. Today, good evening, everybody. Today, I'm going to discuss about vasectomy. Yeah, these are the topics I'm going to discuss today. So first I will introduction, then indication, and also the pre-op concerns, and the anesthesia, antibiotic for any other surgical procedure, and surgical techniques and occlusion techniques, and following the vasectomy, the sterility, and the failures, and also the complications. Mainly I will concentrate on the first vasectomy pain syndrome, and if time allows, I can talk something about vasectomy reversal. My references are AUA guideline and EAU guideline, as well as the BA, British Journal of Urology knowledge. It is the safest and effective permanent contraception relied by around 40 to 60 million men in the worldwide. And also it's a safe and effective permanent contraception. It is being highly litigious because of its rare failures. This is the UK trend towards the number of surgeries done annually. So there is a reduction in number of surgeries with time. This might be due to the emerge of new contraceptive methods, and litigations might be. I want to touch some part of the history. This surgery initially started around 1830 by the Sir Ashley Hooper. Then it was modified and got the popularity, Steinach as procedure. Then there's no significant absolute contraindication for vasectomy. Only there are some relative contraindications. So age less than 30 years, absence of children and severe illness, no current relationship, and scrotal pain. And since here the litigation procedure is there, high with a vasectomy, all the guidelines suggest we have to give a preoperative consultation with the patient, which should include these topics. So we have to have the thorough medical history, and as well as they have to continue after the vasectomy, the contraception for 3 months duration, because there might be, we are just cutting off the vas, so rest of the system, seminal vesicle might have sperm, so it might take around 3 months, and also 20 ejaculation approximately. So we have to educate the patient to use contraception for 3 months duration, and complications and possible failure rates which are less, and potential for fertility restoration with sperm banking or vasectomy reversal is there, but it should be considered as permanent contraceptive method. Availability of alternative methods should be discussed with the patient, and also we have to tell them in some literature they say increase cancer and some comorbidities, but there's no significant evidence that there's no increased risk of prostate cancer or testicular cancer and cardiovascular disease and hypertension or dementia. And after counseling, we have to do a preoperative examination. During that procedure, what we are looking for is, we have to look for, are there any genital pathology, and also the patient is a good candidate for a local anesthesia. I will discuss about the mode of anesthesia here, and the patients who are not good candidate for a local anesthesia are where the vas is very difficult to palpate, and the patient is having sensitive scrotum, and the patient is very anxious for the local anesthesia. So we have to identify these patients preoperatively. So the anesthetic anesthesia, mainly we can use local anesthesia. That is the recommendation if the patient is, other than this previous indications are not there, local anesthesia plus sedation can be given. The 1 or 2% lignocaine without adrenaline. Why not adrenaline? I think we might be worried about the adjacent blood vessels. And small caliber needle, since we are doing it on local anesthesia, small caliber needle is preferable, and also jet injectors. I think we don't have that facility, but in other countries they use the jet injectors. And according to the guidelines, they don't suggest any prophylactic antibiotics. So this is the technique where we use the to identify the vas to administer the local anesthesia. As I can remember that during the past part 1 MCQs, we get the question that how to identify the vas. So that might be the highly muscular palpable tube. If you do the examination of the spermatocord, we can identify that. So after that, we can locate it and we can give the anesthesia. And surgical technique, of course, we have to consider 2 main things. One is isolation of the vas, and we have to, other thing is occlusion of the vas. Effectiveness of the procedure mainly depend on the method of vas occlusion, and the complication rate is mainly depend on the access to the vas. Vas isolation. There are 2 techniques. Previously, the open technique or incision conventional vasectomy techniques, and currently the recommended technique is non-scalpel vasectomy, NSV. AUA and EU recommend that, and there are literature also. There are level 1 evidence are there. Non-scalpel versus conventional vasectomy. Non-scalpel method is having less complications, and also it has early recovery. Even though it's a the name implies that no scalpel vasectomy, it is a misnomer, where we will use single or two horizontal incision or single midline incision around the penoscrotal junction. This is the isolation procedure. Two special instruments are employed: extracutaneous ring forceps and dissecting forceps. Here, of course, they have shown that non-scalpel technique, but normally in literature what they say is it's a misnomer. So these are the techniques how you apply the ring forceps and identify the vas, then how to we dissect the vas and we take it out, and then we can use the occlusion techniques. So occlusion techniques there are two main techniques where we can either divide the vas and excise part of the vas, or otherwise without the dissecting and ligation, we can destroy it with the diathermy, which is called the Mary-Stopes International Technique, where we cauterize the vas for around 2.5 to 3 centimeter. And other common techniques are complete excision, division, and excision with the part of the with the excision of the part of the vas. And also there are other techniques with the complete divisions, which are to prevent the recanalization. The early and the late failure rates of vasectomies associated with recanalization. To prevent the or reduce the recanalization, there are some methods used during the surgery. One is fascial interposition. So after taking the vas, we put one part of the vas, end of the vas, inside the peri-vas tissues, and the other one open. So fascial interposition will be there, and other part is we can ligate either ends and we can apply clips, or otherwise what we can do is we can cauterize the vas mucosa bilaterally up to 1 centimeter, and we can do an open-ended vasectomy also. This is
2 minutes.
Okay.
2 minutes.
Okay. This is the ligation and excision of the, these are the pictures where we, the fascial interposition, and here we use the mucosal cauterization. And here, these are the pictures where they will show the method of doing the occlusion. Here, mucosal cauterization and ligation clip occlusion. This is the Mary technique of cauterization. There are different ranges, but I think with the guideline I can come to it. So evidence, even though there are different occlusion technique, the data are not a proper data available. Cochrane review, recent Cochrane reviews suggested that fascial interposition appears to improve the effectiveness related to the one randomized control trial, and also regarding with this Baron and et al. Study, observational study suggested that electrodiathermy also seems to be effective. So the guidelines, of course, recommend vas occlusion technique with a reported failure is 1%. AUA suggests these 4 techniques where you can use the non-dissecting technique as well as the mucosal cauterization and fascial interposition. EAU, of course, didn't mention about the Mary-Stopes, where we can just damage the vas with the diathermy. That technique they haven't mentioned, but they recommend mucosal diathermization as well as the fascial interposition, which is associated with minimal failure rate. So about the contralateral vas difference. So we can so you do the surgery on the single site, and we have to repeat. We have to do the same thing on the other site. We can do it through the same puncture, or we can use the another incision. But when we are doing through the same incision, we have to make sure that we are doing identifying the both vas differently, because sometimes mistakenly we might resect the same vas in 2 points. So to do that, to identify the both vas differently, we can do a gentle tug on the vas, and its lateral testis will move up. So by doing this maneuver, we can identify the sides of the vas. And post vasectomy, when we consider the patient sterile. So as I mentioned earlier, 3 months period, according to the guidelines, they have to use the contraceptive methods until for 3 months. And after 3 months, we have to go for a semen analysis, where we have to take the uncentrifuged sample, not the centrifuge sample. And there we have to find out the patient should have either azoospermia or rare non-motile sperm, which is considered as a less than 1 lakh non-motile sperm per milliliter. Guidelines recommend it should be done in 3 months duration. In some, the time is controversial. So what they say is after vasectomy, 20 ejaculation should be there in 3 months time. Vasectomy failure. Vasectomy failure, of course, we can divide it into early failure and late failure. Early failure is 1 to 3%. Several studies have shown that where the men sperm counts below 1,000 to be negligible. Motile sperm is more than, or when the motile sperm is present, once fertile motile sperm is present, or more than 100,000 non-motile sperm is present. Then we have to, after 3 months, then we have to consider that still they are fertile. So fertile, so we have to repeat the semen analysis every 6 weeks, and we have to do the test after 6 months. If still they persist to have this motile sperm, or no, more than 100,000 non-motile sperm, we have to consider it as a vasectomy failure. The causes for the vasectomy failure in the early part, we might have occluded the wrong structure. If we didn't identify the proper vas, we miss, and incomplete occlusion, and occluding the same vas in the different place, and there might be rare chance to have dual vas. So the delayed failure, initially found to be sterile, later they become fertile. So this is mainly due to recanalization. The percentage is 1 in 2,000. And other complications are scrotal hematoma is 2%, and infection wise up to the superficial skin infection to epidermitis or epidermochitis, 0.2 to 1.5. Early failure is this one, and Fournier's gangrene and the infective endocarditis. These are very rare occurrence. In UK, time to time, what they say is 1 or 2. And late complications are late failure, as I mentioned earlier, recanalization, and scrotal fistula. There are 2 types of fistula: vasocutaneous fistula and vasourinary fistulas can happen, and post vasectomy pain syndrome, which is 1 to 14%. I want to talk something more regarding the post vasectomy pain syndrome. This is
Please finish quickly.
Okay.
Time.
So patient might be having post vasectomy patient might be having a pain or dull like pain in the epidermis or testis, where we have excluded other urogenital tract pathology, and the pain should be more than 3 months duration when we have to consider it as a post vasectomy pain syndrome. Where pain might be unilateral or bilateral, it might radiate. And etiologies are because of the ligation of the vas, there might be proximal epidermal congestion and inflammation. It might be due to the chronic interstitial fibrosis, and also we might leave the proximal length of the vas, so there might be sperm extravasation, and related to the immunological reaction, there might be pain. And sperm granuloma may be there, sometimes they may be tender. And also we might damage the nerves, that also may cause a chronic neuropathic pain. And also vasectomy can result damage to the facies, which might be due to the chronic pressure. There might be loss of Sertoli cells and testicular fibrosis, which may also contribute to etiology of the post-vasectomy pain syndrome. So these are the details. They will have the poor quality of life. So initial management will be conservative, then scrotal support and these things. And later we can go, first thing is we have to exclude the neuropathic pain. If we misdiagnose the neuropathic pain as the post vasectomy pain syndrome, then there are options to offer. So surgery, testicular denervation can be done, vasovasotomy, that means reversal, epidymomectomy, or inguinal orchidectomy. These are the options to offer for this pain patient. But we have to make sure that the patient doesn't have a neuropathic pain. If the patient is having neuropathic pain, these things may worsen the condition. And vasectomy reversal, these indications are the patient might change the mind to have children according to social issues, and also post-vasectomy pain syndrome. These are the indications. So even
Jonathan, I think time is limited.
Okay.
You can run through the slides.
Yeah. Vasectomy reversal, even though it's a permanent one, 5% can end up in reversal procedure. Indication, of course, I have mentioned, but even though it's a compared to the LRT, this reversal is more favorable, but with time, the factors will limit. With time, there are changes in the vas, secondary obstruction, and also the epidermis blowout. So with that, there might be, even after going for a reversal, there might be failure to have sperm production. There are types of surgeries we can offer. These are the surgeries: vasoepidermostomy or vasostomy. So according to the time of surgery, we can decide what surgery we are going to offer, and according to the patient preferences. So tubal patency, of course, getting a positive sperm count after doing the reversal. So the counts are different. That's all. Thanks a lot.
Thank you, Shan. So one question: if you excise one part, excise the part of the vas, is it necessary to send that part to the histology?
According to the guidelines, AUA and EAU guidelines, we don't have to send it routinely. If we are suspecting something, and if we are not sure whether we have removed the vas or not, in the clinical basis, if you want, we can send. Otherwise, it's routine specimen is sending specimen is not recommended.
Nishanta, have you
Yes.
done any vasectomies, or have you seen being done in Sri Lanka?
Yes, in our unit, we have done one after becoming the urology trainee. I have seen one, sir.
Okay, I was asked the same question in UK. At that time, I have seen none. So they said that we are a very barbaric country. That's what they said.
So this one?
The vasectomies are not referred to urologists. That's the problem, really, isn't it?
Yeah.
There was our predecessor, my predecessor, Dr. L.M. Pare, was an expert in vasectomy because he did part-time visiting to this family planning section. So he was doing so many vasectomies. But when I came, that actually I didn't practice that part, so that a very occasional vasectomy will come to us by the patient's preference, not from the family planning department. So one simple, short comment on the technique, what I do is, the small number I have done vasectomies, I follow this fascial technique with a little modification popularized by Indians, that is to bend the vas, burn the edge and bend the vas on its edge and then tie it, rather than just tying it so that the lumen is open. So, so we will just bend it 90 degrees and tie it, and then push one part fascia and leave the other part outside. What the Indians say is that, that is they do thousands and millions of them. So what they say is that in the hands practice that gives better results than just cutting and separating it. It has failed to come to the guidelines yet. But I think the experience in vasectomies among urology trainees and even neurologists is rather limited because it is done by MBBS qualified doctors, mostly in this country. So I don't know whether others agree. Do they refer vasectomies to you all in the regional centers? Or?
No, sir, no. Actually, it was the same in UK, I think. Most vasectomies are being done by general practitioners, not by urologists. But if the patient has certain conditions, if the patient doesn't want to undergo it under a local anesthesia or needle phobia or something like that, then the patient comes to urology department to get it done under some sort of anesthesia. Otherwise,
and the recurrences, Manoj.
Yes, recurrences.
Failures, they refer to us.
Final question from Nishantan. You mentioned about urinary fistula.
Yes,
I
sir.
understand the morbid anatomy and the pathophysiology of making. How do you explain it anatomically?
Anatomically, what they say is when the patient is having a high pressure system, then there might be, when they have a high pressure system, urological system, there might be a reflux of the sperm contents. So they might develop urinary fistula. That is rare. What they have mentioned in the BAUA knowledge.
Yeah.
So I also saw that it come from the ejaculatory duct and then go backwards.
Right. And
So
then
I
they
think,
rupture into the urinary system, is it?
Yes.
Bladder or someplace, is it?
To the urethra, the prostatic urethra.
Prostatic urethra. Okay.
So probably is it something related to ejaculatory duct related reflux? So.
Yeah, yes, sir.
And so I think it's interesting to know the statistics of vasectomies in this country, because we hardly see any people getting the vasectomies done. Probably something to do with the 5,000 rupees grant which was given earlier for a vasectomy, which has made a big taboo in the community. And it's very interesting to see how many annual number of vasectomies done in Sri Lanka, because I think numbers are going to be very low.
I think so. In our time, there was a period where the people were paid 500 rupees for a vasectomy. And just before my time, a lot of young boys were brought by their parents from faraway villages, and the vasectomies were done. I don't know on what ethical basis they did it, but those people, at least few of them, came back during my time for vessel reversal. And to my greatest surprise, I found that they have got the vasectomy done for money. And I have done vasovasostomy on them, but I think with rather poor results. So there was a time, I think everything was money for vasectomy. Like for tubectomy, they were paying. So adolescent boys were subjected to this. I mean, you can't even believe that. I think we should not be mentioning this in any kind of international forum.
Yeah, Dr. Subhanga, we will move to the next
so, yes. I think the last topic is the penile fractures, hot topics during last few weeks, and done by Tilina Samara Singha, and he has 10 minutes. And over to you, Tilina.
Hello. Yeah. Good evening, everyone. I hope you can see my slides and hear me.
Yes.
Okay, so this is about penile fractures. I'll make a very brief description and try to stick to my time. So the definition of a penile fracture is disruption of the tunica albuginea with rupture of the corpora cavernosa. And the anatomy wise, it's the corpora is, or the tunica is actually weakest at the ventrolateral aspect. So because of that, most of these fractures tend to be in the ventral aspect. And the tunica is supposed to withstand a great significant amount of pressure without rupturing. So fractures are relatively rare. So with regard to the etiology, multiple etiologies, as you can see, can lead to penile fractures, and the etiologies have been significantly different in different parts of the world. So, for example, in the West, it is mostly due to sexual intercourse, but in African, some Mediterranean or Arabic countries, it is actually due to masturbation and this forced flexion to achieve rapid detuminants. So regarding presentation, the classic presentation is said to be a sudden popping or cracking sound with sexual intercourse, as well as rapid detuminants, which is associated with that. And then, as you can see, the Obagain or the eggplant sign is when the dartos is intact and the tunica is ruptured. But if the dartos is also disrupted, then you have spreading of the hematoma and the butterfly sign with the perineal hematoma. Differential diagnosis, we have to consider vascular rupture and also suspensory ligament fracture. These can be identified clinically because there may not be rapid detuminants as with penile fracture, and with suspensory ligament fractures, they say there is an increased mobility, but the patient can achieve erections after the event. So evaluation is basically mainly clinical, looking at the deformity and deviation of the phallus, and importantly, we have to think of concomitant urethral injury, so look for blood at meatus. Regarding imaging, ultrasound scan is not absolutely necessary for diagnosis because the classic history and the examination findings will direct towards the diagnosis. But in equivocal cases, ultrasound scan may be important, but and also in current practice, sometimes to plan the incision, which I will discuss a little bit later, ultrasound scan may be important to localize the hematoma and exclude bilateral corporal injuries. MRI is the most accurate diagnostic tool, but it's not commonly utilized because of certain limitations. So this is an ultrasound scan which can be done quite easily with the superficial probe. As you can see, the corpora cavernosa and the hematoma can be visualized with the especially helping to localize where the corporal tear is in the swollen penis, so that we can plan our incisions. So going on to management, now the current recommendation is immediate surgical exploration and repair of the tunica. So I'll just discuss about these questions. Why not conservative management? Whether immediate or delayed is preferable, and incision, and about urethral injuries and the repair technique, and some follow-up instructions and expected outcomes. So why not non-operative management? Initially, non-operative management has been described cold or hot compressions and basically non-operative observation, but it is associated with higher complication rates and inferior erectile outcomes. So it is no longer recommended to have an non-operative management. Regarding the time of repair, early repair, not urgent, but early repair is advocated. The evidence is slightly mixed, but generally it is recommended within 24 hours to go ahead with the repair. Some studies have advocated up to even 7 days of repair, but there is a large RCT showing that after about 24 hours, the outcomes have been inferior than the early repair. So it is recommended to do the repair within 24 hours, but the fact that it is delayed is not an indication, or we should not defer the repair because it is a delayed presentation. What incisions to use? There are multiple incisions that have been described and none have been found to be significantly superior with evidence, but the commonly used one is the subcoronal circumcising incision, which gives external access to the whole 3 corporal bodies and can be for comprehensive evaluation and repair can be utilized, but it is associated with significantly higher morbidity regarding the incision, and especially because this is the fractures usually occur at the proximal 1/3. There will be a lot of dissection from the distal aspect of the penis towards the penoscrotal junction region. So now most, I think recently we had this discussion in our group also. Think ventral longitudinal incision may be preferred, especially with localization of the fracture with ultrasound scan. Most so surgeons consider the ventral longitudinal incision. And, regarding urethral injuries, it's about 5 to 6% in most series, and we have to be mindful of it. Retrograde urethrogram or a flexible cystoscopy is advocated if there is any doubt of urethral injury. And regarding the repair, it's a simple repair over the catheter while repairing the tunica is adequate, and subsequent stricture rates, according to the evidence, is very low compared to other urethral injuries. They're associated with penile fracture. If you repair it over the catheter, they say the results are good. The technique, the principles are basically exposure, evacuation of the hematoma, identification and repairing, and repairing the urethra if needed. And as we discussed earlier in the previous presentation of Peronis, absorbable sutures are what is preferred in this in the review articles that I have referred. Simply because palpable knots and long-standing sutures will be bothersome for the patient subsequently. But I don't think there is a absolute contraindication for an absorbable. Interrupted or running, it they have not shown any benefit. Invaginating the knots, and also as I mentioned, can check for tunical closure with saline or methylene blue injection following the repair, and urethra can be repaired. It has to be repaired. Follow-up instructions will depend on different surgeons, but the recommendation is basically catheter should remain for 7 to 10 days and abstain from sexual activity for 4 to 6 weeks. And early erections may have been may lead to dehiscence, but there is not suggested to have any erection suppression medications. And also reassurance is important because the patients are quite worried and they might have subsequent anxiety and risk of recurrent fracture, and erectile function may be impaired because of psychological stress. So going on to the guidelines, well, AU guidelines doesn't give a lot of recommendations. This is what it says. AUA has a little bit of a summarized guideline. So regarding diagnosis, exploration and repair, ultrasound in equivocal findings, and urethral injuries has to be evaluated. So in summary, it's rare but important. Classic history and examination usually will lead to the diagnosis. Ultrasound may be used judiciously for localizing the lesion as well as in equivocal cases. Urethral injuries has to be addressed, as I stressed a couple of times, and early exploration and repair has excellent outcomes. So these are my references, and thank you.
Thank you for an excellent presentation, and you are stick to your time. One question, do we want to do MRI scan in each and every case of penile fracture if the facilities are available, or go by clinicals?
From what I gathered from my references in a couple of days, I don't think there is an indication to do MRI, a very limited indication, even if it is available, I think, because not much of an advantage if you can localize the tear and repair it by doing an MRI. But if there are equivocal cases where you are in doubt whether to explore or not, or you can really localize the tear, I think that should be a very selective indication to do an MRI, even if it is freely available. But in our setting, I don't think there is an indication to do MRI, especially with because ultrasound is good enough to detect most of these tears.
Good presentation, Tilna. Just a light-hearted comment. What is the sound you get when you get the penile fracture? I'm sure I would have given you the answer. My professor used to ask me all the time, my previous professor, Professor Ejaculatory, exact sound you get when you get the penile fracture. It is nothing else other than Budu Ammo, right? Okay. Budu Ammo. All the other sounds are, I think, inferior to that. But that is a light-hearted comment. And important thing is that one comment on this, the anterior fractures, anterior hematomas and fractures, you have to be a little careful about preserving the dorsal penile nerve and the artery. Vein may be sort of injured, you can ligate it, but dorsal nerve of the penis, if you accidentally ligate or if you don't separate it first before you start suturing the cavernosum, you might end up in a anesthetic patch in the glans penis. So there's a possibility. So be a little careful when the tear is extending more anteriorly, dorsally. So other than that, I think you have covered up more or less everything in penile fracture.
It's Sohan or Manoj, any comments?
To be honest, Suranga, I have seen only single penile fracture up to now, which was in UK. In Sri Lanka, when I was a senior registrar and after being consultant, I haven't seen a single penile fracture in Sri Lanka. UK only one I have seen.
Actually, same story with me.
After repairing the penile fracture, do you want to give some medication to prevent reduction for a few weeks? So that's the question, I think.
I don't think so, Suranga.
Yes.
I think avoid sexual somersaults and reverse
Yes.
horseback positions and things like that. So that is the only thing we can say about it. Other than that, I have seen about 3 or 4, I think, during my lifetime. You are right. It's pretty rare now in this part of the world. But being called for large hematomas, sometimes delayed presentation. But it's not common. I agree.
I think they present a little bit more to the private sector rather than the government sector as much as possible, I think, because of obvious issues. But even then, I think I have seen only about 3 cases over the last 10, 13 years. Yeah. And none of them with urethral injury. So any with urethral injury that you have seen here?
Yes, out of them, 1 or 2, I think when you explore the spongiosum, there's a little spongiosal hematoma, and when you inject saline with at the tip, there was a little bit of swelling there, so extra resection, right? So we had to separately suture the urethra, but that is pretty rare, I agree.
Yeah,
because it's so stretchable, the urethra, and this mechanism of rupture, urethra won't get involved that easily.
Tilina, what sex position is more risky?
I think we had this discussion in the WhatsApp group as well, but the urological clinics say it's doggy style, I think, for rear entry.
Oh, woman on top.
Yeah, woman on top and sex on hard surface. Woman on top.
Reverse back is woman on top with the reverse this thing. So where the penile, generally the penis in erect position is close to the abdomen because of the suspensory ligament, and so reverse back, the mechanism is such that there's a possibility of bending. But we are fortunate that we don't have that practice of bending the penis to get rid of tumor cells, like in Pakistan. And
Middle East, yes, yeah. Egypt, and yeah. And sometimes there may be avulsion of suspensory ligament of the penis in the, how it can happen. So how to differentiate that from this? Then of course there won't be any swelling in the penis, isn't it?
And they said in the document that the patient will have the normal erection with a very mobile penis. With the erection, the penis will kind of stoop downwards because the suspensory ligament will actually hold it up.
Yeah.
Same thing happens in penile lengthening procedures, which were popularized at some stage. First thing they cut is the suspensory ligament, so they get the erection, but you can't get it upright. So that is another place where suspensory ligament is electively cut to show get some penile lengthening. So that was popular at some stage. Still people do it, but the rigid erection, the penis will not go above 90 degrees in that.
Right. Any overall comment or anything want to tell to the trainees, sir? The Andrology 2, we have covered 5 topics today. Overall comments, sir, Neville sir and Ajit sir.
Ajit, would you like to make a comment on this?
Overall comments wise, I think subfertility wise and the subfertile male subfertility, the handling and the dominance by the urologist is actually has to a great extent been taken away from us. So I think just like erectile dysfunction, we have to sort of start taking it on much more than what has been done previously, because even some of the gynecologists and will go on to managing the partners of infertile females also. So I think moving on to more specialized andrological assessment of these patients and microsurgical procedures and doing some of these vasovasostomy, vasoepididymostomies and the other procedures that are relevant to stamping our role in andrology is very important. And I must thank the organizers for having 2 specific CME programs for dedicated to these two areas, so that we also feel kind of empowered and interested to take it on, and the trainees probably will take it on once they come back. Thanks.
I agree with Ajit, and then these areas, especially the andrology overall, 1 and 2, I think very useful to update our knowledge. And the trainees have done an excellent job. I think they have done their homework very well. And then a few points I think entirely new to me also. And I think I recapitulate a lot in their presentation. Only thing is that I must mention that in future, you must try to keep your time. I'm not blaming you, I'm not sort of pointing a finger at you, but then this is a kind of a training for you to present in international fora, international meetings. So where the timing is extremely important. So just when you organize your presentation in such a way that interesting and more advanced and interesting sections are emphasized, and other general comments are just rushed through. So learn few tricks of the trade, and before presenting, practice it a couple of times, in front of a mirror, or with the timer inside of you, and then make sure that you keep the time, because it's important part of involving you all in these presentations. Other than that, I think it's an excellent program, this part 1 and part 2 of andrology. And as Ajit said, I think we have to take back what we are slowly losing, and especially the penile work, like penile prostheses and erectile work. I think in future, we should pay more attention to that. So thank you very much for the organizers and the conveners. An excellent job. Thank you.
Thank you, sir. Uromet 8 will be female urology, and Dr. Taha and Dr. Suranga for the completion.
Okay, with that, we'll come to conclusion of andrology part 1 and part 2. It was a nice evening to share knowledges. I would thank, we started the discussion with, facilitating conception, fertility, and then erection, and then varicocele. And then on the other side of the coin, the contraception, vasectomy. Then we carry on with penile trauma. Actually, I also like the climax, preventing penile fracture, and which is useful academically as well as non-academically, I suppose. Anyway, thank you very much for our eminent expert panel, Professor Nabil D. Pereira sir, Professor Ajit sir, as well as Dr. Anuruddha Kunasekara sir, as well as Dr. Manjula Vijayawardena couldn't attend due to personal commitments. And I would thank Dr. Manoj Vishkramaratne and Dr. Sohan Pereira. Our talented trainees, they have done a fantastic job. Dr. Ruvinder, Dr. Sanjay Marasinghe, Dr. Niroshan Kodikara, Dr. Nishantan, as well as Dr. Thilina Samarasinghe. I would thank Dr. Balagobi and Dr. Nishantali Anapatran to organize this Uromet. And then I would like to thank Dr. Suranga for moderating this event.
Dr. Kalana want to speak, I think. Yeah.
Yeah, and I would like CIPLA for backing up and sponsoring this event. Yeah, Dr. Kalana, yeah, over to you.
Yeah. Hi everybody. I think it's been a tremendous improvement since its conception. This is the 7th Uromet. I think we can see the presentations and the discussions are gradually being standardized now, almost in the international level, but we can see now. And next month, being October, we'll be having South sessions. So we will have a break in October, and we'll have the usual Uromet in November onwards. What's the arrangement, Gobi?
we are planning for an exit exam as well.
Ah, yes.
So then we have to cover the topics.
All right.
But I don't think
Okay.
this will, the Uromet will affect the sloughs. That's, this is a one night.
Ah, okay then. Right. So 22nd probably. Okay. Right. Okay, all the best. Well done,
Okay,
guys.
then. Thank you very much, everyone. Have a good night.
Thank you very much. Good night.
Nice weekend.
Thank you.
Thank you.
Thank you. Bye.
Thank you.